Good morning, everyone. I will be talking about the surgical challenges and management of fibrotic and calcified anterior capsule in patients having mature cataract. Nowadays, we don't see so much of mature cataracts, but in rural areas, we do get mature cataract with calcified anterior capsule, fibrotic capsule, and there are certain challenges which we may have to face while performing cataract surgery. Because these are associated sometimes with small pupil pseudo-exfoliation, subluxation, or dehiscence of the zonals. Now, what difficulties we face while performing cataract surgery in these patients? As the cataract is white, sometimes it is difficult to perform capsulorhexis, difficult to see the capsulorhexis while performing it because the capsule is fibrotic calcified, and we'll see what happens if we see the star folds on the capsulorhexis on the anterior capsule when we go for the capsulorhexis. Now we'll see case by case what happens while performing cataract surgery in patients having fibrotic and calcified anterior capsule. This 70-year-old male presented to us with mature cataract having central calcified capsule, and you can see some of the fibrous strands which are there. Now you can go with your usual steps of performing cataract surgery, stain the capsule and the clear corneal incision. Now sometimes if you are in habit of performing capsulorhexis with the help of forceps, you may not be able to pinch the capsule. So you may have to use needle to make the initial opening on the capsule, and may have to cut this fibrotic thick anterior capsule with the help of scissor. So you have some opening in the anterior capsule, but it is irregular, and in an attempt you may cause some zonular dehiscence. Now this is the edited video. It took around 5 to 7 minutes to perform the anterior capsulotomy. So there could be zonular dehiscence, we don't know. And putting the endocapsular ring later on would be difficult part, because you can see there are a lot of anterior capsular extensions and the CCC is not regular. So putting endocapsular ring is a good option in these patients. Performing phacoemulsification with such a brittle cataract is not a problem. With your usual parameters, put intraocular lens of your choice, dial it properly into the bag. But in post-operative cases, sometimes you may face contraction of the anterior capsule. So it's good idea to cut the anterior capsule and make it on the bigger side, that is enlargement of the capsulorhexis margin. This is the post-operative photograph of the same patient having calcified anterior capsule but bigger rhexis size. So tips is to need to have a good micro scissor and forceps. CTR implantation you can differ depending upon your choice, but if you have a irregular anterior capsule or you have taken a lot of time for cutting the anterior capsule, it's always a good idea to put capsular tension ring and chop technique as less stress on the zonals. Zepto and femto, I don't have any experience about this technique, but many people they talk of these techniques in these difficult cases. Second case, 65-year-old female presented with pain, redness, watering, having signs of lens-induced glaucoma and diagnosed having phacolytic glaucoma. After control of pressure, we took patient for cataract surgery. She had this Morganian cataract with calcified anterior capsule. The capsulorhexis wasn't that difficult, but the main challenge was performing phacoemulsification. As you can see, the lens is moving inside the bag, and putting a pressure while performing phacoemulsification or initial chop could be a problematic affair. But once you have a first chop, you can later on go for the phacoemulsification and the IOL implantation. So tips in this case is bevel down, phacoemulsification is a good idea because you will have a good hold on the lens while performing initial chop, and most of the tips they are available either in the 30° or 45°. 0° tip would be ideal in such cases, but if you don't have 45°, you can do the bevel down and have a good grip of the nucleus. Vacuum should be optimum. Remain in the center part and do not move probe towards the nuclear fragment, and there should not be any surge because there is no cushion of the epinucleus while performing phacoemulsification in such cases. Case 3, 80-year-old female, hypermature cataract with calcified anterior capsule, and we had problem while performing capsulorhexis. In this patient, we tried to perform phacoemulsification, but the main sign we could see was the star fold on the anterior capsule while after performing the staining of the anterior capsule. So we thought the capsulorhexis would be difficult in such cases. So initial cut was with the help of 26-gauge needle, and we tried to engage the capsule with 26-gauge needle, but it was a big capsulorhexis opening, and this part was good. We could remove the capsulorhexis plaque, but it got extended towards periphery little bit, and it was a bigger one. The nucleus was also very hard. So we thought of converting this case to small incision cataract surgery, because in these patients, vision at the end is important rather than your technique of phacoemulsification or whatever. So this case was converted to small incision, bigger nucleus, as most of us are doing SICS in hard, brown, black, leathery cataracts, so it's not a problem, and putting IOL of your choice. So SICS comes handy in such situation. So in conclusion, capsulorhexis, anterior capsule staining is important. CTR, you should have a backup of vitrectomy if at all you find that zonularhexis is there, zonular capsulorhexis is there, and always have CTR in your armamentarium, and if you find there are any difficulties, you can always convert to small incision cataract surgery. Thanks for your patience listening. Yeah, in these cases, my parameters are power around 60 to 80% linear mode, and vacuum of around 350 to 400 cc. It is also linear, and phaco chop I prefer in a burst mode initially, or maybe in a pulse mode, that is 6 to 1. Yeah. 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 In such, yeah, in such cases, what we do, whatever chop possible, we try to do. It's like a flower petal which creates there. So you can remove whatever nucleus comes. Each petal you remove. Yeah, center remains bowl. You can go to epinucleus mode in such cases, like if high vacuum and low power. And whenever occlusion comes, go to third foot switch position. The plate comes out easily. But you need to form the anterior chamber off and on, because thing is that you are more towards the endothelium at the end of the procedure. Yeah, always a problem. Right. No, in particularly with hard brown cataract with calcified capsulorhexis extending towards periphery, and you find that the phaco won't be possible in such cases because your extension may go towards periphery, because phaco time would be more, surgical time would be more, and very old patient wherein the vision is important in such cases rather than your technology. Thank you.
Okay, so basically, I don't know how to do SICS. I do 100% phaco in all the situations, and I have developed my code to crack nucleus. And what I do is, I go and embed, I go and engage, go and embed, do lateral separation. यहाँ तक तो सबको पता ही है. But what is, then you pronate. So when you pronate, the crack goes deeper. And that stretch goes down significantly. No, this, you see, ultimately you have to generate lateral separation, isn't it? So whether you hold here and here or you hold here and here, it does not really make a difference. Very dangerous. So basic rule of surgery is you should see whatever you are doing. I use 100% Sinski. So that means the chopper is not important, the machine is not important, the tip is not important, the technique is also not important. What is important is that you should realize that lateral separation is the key factor. So, so to go reduce the stretch, you do tangential movement and you do pronation. Your stretch will go down significantly. And as a VR guy, you will understand it very well. So ladies and gentlemen, today we are coming to a new, an innovative vista, and that is human analog to AI. So whenever we talk about human analog, people just forget the human part and they consider that we are talking about artificial intelligence. But actually we are not talking about AI, but we are talking about human analog. So should I call you on the stage or are we good here? So good. The concept is that we have a team here. I will be doing concept introduction. Data presentation will be done by Dr. Malay Chaturvedi. Standardization and strategies will be covered by Dr. Malay Chaturvedi. Identifying VTR will be done by Dr. Manish Saxena. They are all very senior experienced retina surgeons. Slide presentation, this is a very interesting part, most interesting part. We'll give you voting pads, we'll give you some slides, and we'll ask you to choose whether to treat or not to treat or can't say. So whether you are a retina guy or you are not a retina guy, you should participate, and I've told my audio-visual team to do the voting also. So can you do that live thing that which I have said? Mobile, yeah. Are you doing? Great. So that's your specialization. Thank you very much. And then Professor Ajay Dudani will be talking about clinico-investigative correlation. See, what happened when we started doing this program 4 years back, we were almost teaching diabetic retinopathy. And then we realized that actually this is not a teaching program for diabetic retinopathy, but we are doing something else. So what is human analog? Human analog means whatever we want a computer to do, can we do through humans or not? That is the human analog. So when we teach our residents, we teach them in a very complicated way. We teach them so many classifications. There's jargon of etiology. We will talk about this classification, that class. I'm also not naming the classification, but there are so many classifications we will be talking about. But when we give it to computer, we give them simplified pictures to identify. And that is the difference between when we are talking about human analog and an AI. So we need to simplify classification, and we have to see that we are talking about a natural course of the disease. So there is a, Dr. Shalini, there is a T-shirt for you. We have got it right from Tirupur. They are very high quality T-shirts. Wear it, you will enjoy it. The texture is very good. Just feel the cloth. They have told you this 140 GSM. Have it. Somebody please give. Also take this voting pad. It will make it interesting. So, you will enjoy it, yeah? Yeah. So this will give color to the program. So AI, you know that is basically dependent on picture recognition. So picture is broken into pixels or arithmetic expressions, and then it is reconstructed into pictures. So there are 3-4 filters through which this picture will be going through, and ultimately we'll know that a dog is a dog. Do you have a pointer? So ultimately we will be able to identify that the computer will be able to identify that this is a dog or a normal retina or a diseased retina. So as of now, what we understand in 2022, that AI in diabetic retinopathy remains a screening tool only. That itself is a revelation that I don't think it's working here. That this is only a screening tool. For example, this OMR sheet which we are using in examination is an example of picture recognition. So the platform which we are talking about, which is recognized by FDA in 2018, is IDX-DR platform. This is essentially a software. That yellow thing is important. We should understand that this is just a software, and it can be loaded on any machine. In this case, it has been loaded on this particular machine. Another thing is important that we should understand that what it does, it identifies more than mild diabetic retinopathy detected, referred to an eye care professional, or negative for more than mild diabetic retinopathy, rescreen. And the criteria which the sensitivity and specificity is quite high, but the criteria which they are using is level 35 of ETDRS. So in ETDRS, they have some levels, and it is using a 35 level. Now, what is that 35 level? So these are the photographs which ETDRS is using, and this is level 35. Level 35 means even if there are certain intraretinal hemorrhages or some abnormalities, the IDX-DR will say, go to the doctor and get your screening done. Now, this is actually, if you see an enlarged picture, then this is what they are using as a standard. What we are doing in human analog. Human analog should have a simplified identification criteria. So we should not give them too much of knowledge. And whenever you think I am crossing the time, just let me know. It should be easy to handle, and we should use available tools. The result target should be achievable, and this should be simple, and then we will have predictable outcome. So we need to understand that human analog, like AI, is also a screening tool. And our identification criteria is VTDR. Dr. Manish Saxena will be talking about VTDR. And you will be surprised why we have allocated one consultant on this topic, which is such a simple topic, because this is the landmark key area on which we will be working. And as far as the literature is concerned, we know that everybody is now talking about sight. STDR is sight threatening, or vision threatening is VTDR. So what happens in 2020, 2 years back, WHO has come up with a European study that aims to improve screening practices and which aims to reduce the benefit, enhance the benefit and reduce the harm. So that is the target of WHO thing. And what they have understood, that if you do screening, you reduce blindness or the harm produced by diabetic retinopathy. So interestingly, what WHO says about who can do the screening, it can be done by family doctors, optometrists, ophthalmologists, physician, endocrinologists, diabetologists, internists, residents, किसी को छोड़ा ही नहीं उन्होंने. So that means they can do, and what they are trained, they should be trained to examine the eye or take an image and grade their findings. So either you should be able to see the retina and see that yes, this is treatable diabetic retinopathy, or take a photograph. This is exactly what we are talking about for last 4 years. So there is a study which has come up in 2021 by South Indian group headed by Rajiv Raman, and that says there is a need to strike a balance between gold standard and accepted protocols. And what is the gold standard? You go and screen the entire Indian population of 130 Arab or whatever billions, but that is not possible. So we should be screening the diabetic patients which are identified. and screening in diabetic clinics rather than population. So we will use human resource. So in 2021, the South Indian group also says, is also discussing about human analog. So where we are as of 2022, we understand that preventable diabetic blindness is a significant challenge in India. Screening activities reduce the incidence of visual loss. VTDR is the standard threshold for referral. Human analog is an important tool to handle the wrath of preventable blindness. It remains a viable alternative for screening of referable diabetic retinopathy. Thank you very much. So now you see, we will share with you, Dr. Malay Chaturvedi will come and say what we have done in last 4 years. We are talking about this for last 4 years, and we have to see what we have been doing for last 4 years, right? Dr. Malay.
Okay, so good morning everyone. Today I'll be talking about the previous experiences and outcomes that we have had in the past 4 years. So coming to a chronological evolution for the entire program, it all began in 2018 where we conducted a CME with difference at Kanpur. Then it was moved on to Uttarakhand State Ophthalmic Society and an exercise was conducted at GSVM Medical College Kanpur. Then we went on to a national level at Gurugram, and then even through the COVID period, we conducted some online surveys, and we went on to the virtual AIOC. And right now we are presenting this course again in the AIOC Mumbai. So how it all began? So first there was a reality check, that is artificial intelligence accessibility possible in the setting of our nation when there are so many rural areas and remote setting places. So actually it is very difficult that AI can reach those areas, and then the need for evaluation of AI for purpose of identification of treatable DR. So what Dr. Malay said previously, that is a machine actually required for such a thing when anyone can do it, which WHO also says. So we need to teach the general ophthalmologists the identification of treatable diabetic retinopathy and simplify the procedure of identification. So in Kanpur Ophthalmic Society, in CME with a difference, this was to set afloat the program which was conducted with general ophthalmologists of Kanpur Ophthalmic Society, and all the consultants were initially educated about the basic pathologies in diabetic retinopathy. So participation was done by all the consultants, and they were asked to fill a survey form. And the only question was that, would you treat this condition or not? And the initial response sensitivity ranged from 55% to 75%. The target audience age group was 40 to 80 years. And we had a positive response. So this enlightened the entire team to move ahead and embark on a journey for the same. So next step was Uttarakhand State Ophthalmic Society in 2019. So encouraged by the previous feedback, an introductory program was conducted in this Uttara Icon, and this was a growth of event to a state level rather than a city level program. So this was again well appreciated by the audience there, and this again gave a positive outlook to the entire team. So now we needed to ponder on ways to enhance our program. So then we conducted it in an exercise in Medical College Kanpur. So this time the participants were ophthalmology residents in training. So the idea behind conducting this exercise was that if success can be achieved at this level, then when ophthalmologists in training can be, pursued to give a positive reply, why not the general ophthalmologists who are experienced and well trained can also be introduced to this concept. So the ICO classification for diabetic retinopathy was introduced, and there was display of random images. So there were 20 students who participated, and all were shown 10 slides to pick. So the simple options were again provided, which was to treat, or should we do a no treatment policy? So this time the sensitivity increased to 80%. So this showed that we are currently on the right track and we should move ahead. So what's next? The next is time to make some decisions regarding how should we move ahead. And then we need to identify a referral threshold. So this is a very important thing, that when we need to know that we need to refer this patient or not. And we need to standardize the concept and then present this entire thing on a mass level. So then we decided to present this topic in the All India Conference in 2020. And this was the first time that this concept was introduced at a national level from our side. So in an instruction course, we told about the basic features of DR first, and voting pads were provided to the entire participating audience, and on-spot voting was conducted. So the goal was to conduct an interactive session and obtain live analysis behind our entire thought. So this was the sample image, and everyone was asked a question, for instance, that is this a picture of retina or not? And they were given 3 options from which they had to choose. So the basis of the course was that vision-threatening diabetic retinopathy features were chosen, and rather than clinically significant macular edema, diabetic macular edema involving center or not was taken up, which is according to the recent ICO guidelines. So the training was done in 2 steps. In the first step, simplified photographs of DR was shown to everyone, and the voting was conducted, where everyone had 30 seconds for a response for each slide. So the responses of everyone was recorded, and random selection of this strata was done to mandate participation. So this was the sample slide that was presented during that course, and everyone was asked a question and they were given options. The answer wasn't displayed at that time. But afterwards, this was the result which took place after the live voting was present and the answers were recorded. So similarly, I have a couple more slides for the same sample that was conducted at that time, and voting was done. So after this first session of voting, the interpretation was that the responses were erratic in nature and everyone had a state of uncertainty and doubt. So after this, the step 2 included introduction of basic criteria of ICO, pictures of certain disease patterns like macular edema, vitreous hemorrhage, NVD, NVE. These were shown. VTDR characteristics were taught, and then again the process of showing photographs and on-spot voting was repeated, and the results were recorded. So after this, we can clearly see that the entire population who was answering, this time they had 60% rate of sensitivity who had correct answers, and only 20% had wrong answers. However, the 20% population also who had divided, they were divided between yes or no. So on random selection and voting, it was observed that there was a predictable outcome. The mandate was very clear in clear cases. So we needed to upgrade the decision-making capacity of the general ophthalmologist, and there was moderate sensitivity rate in borderline cases. So what we learned, that our reference threshold should be VTDR, which is vision-threatening diabetic retinopathy. The target audience should be general ophthalmologists and not specialists. The limitations of AI were demystified over time, and the objective and scope of human analog was better identified. Then we conducted a random online survey of DR for Geo, which was done in May. So a random survey of the study was conducted via online Google Forms, and the response of 23 ophthalmologists were recorded. So this was the sample form which was put up online. And again, the images were displayed, and we had the question that does the image show VTDR features? And options were given, yes, no, or can't say. So similarly, these were the options, and the responses were recorded again. So there was a similar response that we conducted in an IC, even on the online forum. So decision-making was very clear-cut, accurate, hence the education of general ophthalmologists for further management should be done. In borderline cases, answers were still divided or doubtful, Therefore, the moderate sensitivity prevailed. Again, an online survey was conducted in the month of November 2021. This time, however, the responses were recorded of 100 ophthalmologists instead of 23. So this was done on a larger scale, but however, again, similar responses were recorded. So human analog in current scenario, it is analog which we have considered against the artificial intelligence as a screening tool for diabetic retinopathy referral. So it is used to combat the load of diabetic blindness in our nation and availability of prompt services even in the remote parts of our nation. So this is the voting pad that today also you all will be provided, and you can use the numbers 1, 2 and 3 to answer as yes, no or can't say. So thank you so much, and I'd like to invite the next speaker.
So Dr. Mohit is a very prolific retina surgeon, and our group is from Kanpur. This whole concept started from Kanpur only. When Dr. Lalit Verma came, we called them and we said that we are doing a CME with difference. Then he asked, what is the difference? So then he suggested that you go ahead and make up this program. So Dr. Mohit is another fellow friend of us who is doing a fantastic retina work in Kanpur for last almost more than a decade. And he will be telling about a very important subject, how to strategize to do screening, and what are the future what we are going to do. Yeah, Mohit.
Thank you, sir. Good morning, one and all. It's a blessing and a blessed moment today that we are here in this hall in AIOC for discussing human analog for artificial intelligence. I thank AIOC office bearers and special thanks to Dr. Malay Chaturvedi sir for conceptualizing this course and taking me along with him for last 4 years. So I've seen this baby growing, and this is second national forum where we are talking on the same topic. What section has been given to me today is slightly different and difficult. What I mean to convey is where we stand in understanding AI, what are the international standards we have achieved, and what pitfalls are there in AI so that we need to improve or incorporate something beyond AI. When we talk of humongous volume of diabetes in this planet Earth, we see that 422 million diabetics are already there, and we project to be having 640 million diabetics in working age group by 2040. And see this mismatch. We have 1200 trained vitreoretinal surgeons in India, and estimated 3.5 million referable diabetic retinopathy on this very date in India alone. Now, this demanded a lot, and the whole corporate jumped into development of different tools for screening of diabetic retinopathy. We had fundus cameras, handheld fundus cameras, mobile coming in, lenses modification and whatnot. Now basically what we incorporated here is two modes. First is an fully automatic mode where there are sites of absence of a reliable graded or an acquired for all acquired retinal images, and all the referred images are screened by an ophthalmologist, and at least 10 non-referred images are to be screened by an ophthalmologist later. Another one is an assisted or an augmented intelligence mode where there is an ophthalmologist per se, and the images are screened by an ophthalmologist and graded for the diabetic retinopathy status. What basically is this artificial intelligence? See these two pictures. First is supervised learning. You give input data of apple and tell that this is apple. So the machine identifies, yes, this is apple. So you supervise the machine. But then other is an unsupervised learning. When you give lot many fruits and then you develop the neural networks which at least strategize or categorize apples, bananas, and other fruits in different categories. So this is what is an unsupervised learning. So what we can do is generate lots and lots and lots of reference images and develop the neural networks mainly by regression analysis so that the machine identifies what you want to convey. This is what is the whole concept of artificial intelligence. Now, what this current status is for all AI models. There is something called I-grading, ret marker, and IDXDR, and they have been found very much comparable with the results what trained persons were giving. IDX got US FDA approval in 2018 and was the first to get so, and later on IART system got approval in 2020. Google, having an Indian CEO, was very much interested and knew about the burden of diabetes, and so they collaborated with Shankar Nethralaya Chennai and Arvind Eye Hospital Madurai. From there they got the reference images, and big projects are running with coming results every year. Now, what is this IDXDR? Here the images were captured through non-metriatic TopCon camera. There were two images being fed into the camera. First was optic disc centered, another was macula centered. The reference images what IDX was getting was through Wisconsin Institute, and it gave two results, either more than mild DR or less than mild DR. Simple. If it is more than mild DR, it gave a command to refer. If it was less than mild DR, it gave a command to screen after 12 months again. Reference images, Dr. Malay has already shown, they were ETDRS level 35 with the sensitivity and specificity of 87.4 and 89.5. And it is very interesting, the last line is an interesting line, that if we talked of level 43 and above, the success rate was above nearly 100%. So now what these pictures are, they have been discussed already. This table, need not to see any of, this is the evolution of AI. You see, earlier it was only 143, 60, 30 images being studied. Very few, the sample size was not very high. So this is how the results were evoluting, and then you see a huge study coming here. AIOC study and Ting from Singapore. These are the largest studies that came upon, and then they gave the real insight that yes, we can do something with AI. Then, recently, if we talk of last 5 years, what we have achieved are these studies, and Gulshan is the person from Google who really worked with Shankar Nethralaya to get these results, and now we have from 2016 and 2019 work coming from Arvind and Shankar Nethralaya through Google, and this is what we have. Interesting thing in this whole slide is positive predictive value. See, after spending billions of dollars, the positive predictive value is around 50%. This is the key point. So what are the challenges with AI? First and foremost challenge is retrospective and prospective study. All what we are getting from AI is a retrospective result. And unless and until we do a prospective result, if something ajeeb say, you never know what comes the next picture. Machine doesn't know that picture. So machine falters. So we have to be prepared with our gray matter, that what surprise you can have in a patient. Patient is always a surprise box. So unless and until you conduct a prospective study, the results are never going to be natural. Accuracy never means equivalent to clinical efficacy. Machine can be equivalent with what? What is accuracy? What you have fed, the marks are going to be given with that only. So accuracy can never be equivalent to clinical efficacy. Then you cannot compare. Somebody is using this algorithm, somebody is using that algorithm, somebody is giving data of European population, somebody is giving American population. So you cannot compare apples with oranges. No. And machine learning, sometimes there is data set shift, sometimes there is a bias, sometimes there is inapplicability, confounders. So many things come within the machine. Logistical difficulties are also there. There might be cataract, there might be poor acquisition of image. The skill of photographer also comes into role. So not all data in healthcare system is available for machine learning also. You discard many images, but do you need to discard them? They were really diabetic retinopathy and you discarded, so that's not done. So how there has to be big bodies to regulate and quality control, that is still not there. So the baby is still small. This is what I am wanting to say. AI systems fail till date to explain in an understandable way the decision making. So if you have detected moderate, if you have detected referable VTDR, now what? So there is nothing in AI to give you the answer of now what. So the decision making in AI is still very much deficient. So human versus algorithm. The biggest question is, if you keep getting answers from machine, yes, refer, yes, refer, yes, refer. So after 5 years or after 10 years, my question is, did you really reduce the visual disability or you just increase the warning messages and recall rates? You don't know. So there has to be some policy principles. These researchers need to be human-centric, very transparent, ethical and social regulation should be there. And there have been an infancy stage of task forces being developed like Consort, Spirit, START. They are giving standardization to all the AI reporting guidelines. So we are coming up with these things. Organizations are working. WHO, as Dr. Malay said, US FDA is giving approval after some regulated authorities like Radiological Health, Digital Health Center for Excellence, and G20 AI principles are also coming up with the design of policy actions. So now is the role of human analog. There are 1200 trained VR surgeons, but AIOS has 22 ophthalmologists registered. Human brain, I bet, can have more neural networks than any neural network you develop through any analysis in Google. The least infrastructure required is there in our cranium. We can utilize that. It is easy to regulate, supervise, and improvise. And as beautifully depicted by Dr. Abhijat, we have been doing it for last 4 years. So why can't we do it more on a larger front? So let's ponder. Beautiful work done by artificial intelligence people across the globe. Something machine dependent has come. But just blink your eye and think once again. Can we think beyond machines? Can a human analog be developed? Can we learn here in our brains rather than feeding so many things into the machine and finding out the errors? So this is the thought to be had here in this hall. Thank you all for your attention.
So, as we have seen that the concept is introduced, the previous experience has been shared, the future strategies have been given. Before we give you what is the standard criteria by which you will refer, there is a very interesting part. I think that's the best part of this whole program. We will give you certain photographs and will choose you whether you will treat or not treat, or you can't say. So if I show you a photograph and you will say whether will you treat, the answer is yes, number 1, no, number 2, can't say, number 3. So choose whatever you choose, the things will be displayed here. कौन बनेगा करोड़पति में आपने बहुत चूज़ किया था. अब ये जो आप चूज़ करेंगे, ये एक हमारे लिए बड़ा ही यूज़फुल डेटा तैयार करेगा, लाइव रियल टाइम डेटा. Data is presented by Dr. Abhishek Dikshit. He is actually a very active VR surgeon, originally from Kanpur, but currently he is in Banaras.
Yes,
so Dr. Abhishek.
Good morning, everyone. Thank you, AIOS and Dr. Malay sir for this opportunity. Can I have the presentation slides? So this is a kind of clinical exercise which we daily do in our clinics. We see diabetic patients and we decide whether it is a kind of referable patient or we have to just follow. So it's not coming here. So here actually I will be presenting in 2 parts. Part 1 is where I will be showing 12 pictures of fundus photograph, and you have to identify whether it is vision-threatening diabetic retinopathy or not. And after that, Dr. Manish will take over and he will be elaborating about what is actually vision-threatening diabetic retinopathy. And then again, I will show 12 fundus photographs to record your response. So this next, can we start? So, okay. So in this part, there will be total 12 slides of diabetic retinopathy. And the question is whether you have to identify whether it is vision threatening or not. In nutshell, the vision threatening means any microvascular complications of diabetic retinopathy, rather in the form of like breaching of the blood retinal barrier resulting in the leakage, or if you see any microvascular complications like neovascularization. And I hope everyone has the voting pads. So as Abhijat told that there will be numbers 1, 2, and 3. 1, you have to click if you feel that it's vision threatening. 2, if you feel like it's not vision threatening retinopathy. And 3rd, if you are not sure whether if you are confused, then you can put the 3rd one. Next slide. Oh, sorry. Oh. So this is slide number 1. So yeah, if you feel that it's vision threatening, then you press 1. 1. Okay, now 1, 2, or 3. So we'll give you 20 seconds. Can you start the timer? So after 20 seconds, the result will come. How many of you like? So yeah. So 90% feel that it's a vision threatening, and the answer is yes. Next slide. This is slide number 2. Timer. It was 30, sir. I asked them to make it 20. So this is 80% feel like the answer is yes. This is slide number 3. Start timer. So just you don't move slide forward now. We can show them picture for more time. So yeah. Can you show the picture again? This one. So this, yeah. So this is actually the answer is no. We will discuss later. Slide number 4. 4. Yeah, start the timer, please. That's what actually the timer chalega, photo chali jayegi. So this is the response. You don't show the timer, na? We can just. Yeah. Next slide. These are the classical cases. Actually, you just kind of spot diagnosis. I have tried not to put like any confusing pictures, These are the straightforward, you can say. Yeah. So please, next slide. 6. Yeah. This one. What do you think? So, can you show the answer? Yeah. So, this was actually the answer is yes. This is a vision-threatening diabetic retinopathy. Because, can you show the picture? Yeah, because you can see the hard exudates are very near to fovea, approaching towards the fovea. So, we need to investigate more in these kind of patients. Next slide. Yeah, the answer is yes. This is a PDR with large premacular hemorrhage. Next slide. Yeah. So the answer is no, because it's a normal fundus. So there is no DR. So this is next slide. 9. Please start the timer. So yes, the answer is yes. This is a case. This was a case of. Can you show the picture? Yeah, this is a case of PDR, high risk PDR with tractional retinal detachment. Next slide, please. 10. Yes, sir. So yes, this is the case of. Show me the picture then. This is the case of PDR with the pre-retinal hemorrhage and along with the diabetic macular edema. Next, this one. Start the timer. So yes, this is a case of, answer is yes, this is a case of PDR with the non-clearing vitreous hemorrhage. Next slide, please. Yeah, this is the last one. So the answer is yes. This is a case of lasered PDR with thick ERM over the macular area. So these were the total 12 slides. Now I invite Dr. Manish Saxena to come to the dais and teach us about how to identify the vision-threatening diabetic retinopathy, and then we will again show you certain photographs for the Thank you.
Should I start? Again, thank you and a very good morning to all. So basically, I'll be teaching what exactly this vision-threatening diabetic retinopathy and why we should learn this vision-threatening diabetic retinopathy. So before I start, we should focus on this picture. This picture is all about our IC. What we are not against the AI, but we should not forget that we are the humans who are feeding the AI. So we should always be a leading rather than the AI. That's why the need of this IC. And for that, so far what we have learned in terms of diabetic retinopathy is the ETDRS classifications. So ETDRS classification, they told us about mild, moderate, severe, very severe NPDR, and then proliferative diabetic retinopathy. Its classification is easy, but there are so many things, and those are actually difficult to learn. What is mild? When you say it's mild, when you'll say moderate, whether you'll treat it or not. So then it becomes confusing and difficult to remember each and every part of this classification. So that is why there is a need of any other classification, a simple classification, just to remember whether to treat these patients or not, whether to refer these patients to a retina person or not, in terms of a general ophthalmologist point of view. So if you see this mild, moderate, severe doesn't need treatment, and the other three part are actually important one which needs treatment. So this mild, moderate, severe NPDR is non-vision threatening DR, and this PDR and a very severe PDR along with macular edema. These are the three things which we need to focus. Your handouts has been given, though basically it's focused on these three parts, and that is called vision threatening NPDR. So first we'll take a normal fundus photo. It contains optic disc, vessels, central part macula, center of which is called fovea. That all we know. So the first part of vision threatening DR is very severe NPDR. What is that? Simple rule to remember is 4-2-1. What is 4-2-1? If you see intraretinal hemorrhage in 4 quadrant, or you see venous bleeding in 2 quadrant, or IRMA, that is intraretinal microvascular abnormalities in 1 quadrant. I'll let you know what are these three things, but just remember 4-2-1. If you are seeing any of these three, it's a very severe. Any of these two, then it's a very severe form of NPDR. So what hemorrhage we are talking about? So in retina, we see two types of hemorrhage basically. Not two types, many types, but which confuse us is intraretinal and the superficial hemorrhage. So these superficial hemorrhage are basically splinter shaped along with the superficial nerve layers. We will see it's kind of a flame shaped hemorrhage. While if you focus on the deep intraretinal hemorrhage, these intraretinal hemorrhages are more compact, more in clumps, more roundish rather than flame shaped. So that is how we differentiate between these two hemorrhages. So if you see intraretinal hemorrhage in 4 quadrant, not superficial hemorrhage, those are the things which you need to refer to the VR patient, VR doctor. Second, these bleedings are easily, nobody can miss these bleeding. It's kind of a string of pulse. So if you are seeing these venous bleedings in any of the 2 quadrant, then that patients need to be referred. Similarly, this IRMA is actually confusing from general ophthalmologist point of view. It looks like a NVE or neovascularization, and sometimes it's become difficult to differentiate between the two. So first I'll let you know whether whenever you see these kind of branching pattern, if you are not able to differentiate it's IRMA or neovascularization, both needs to be referred to the general VR person. So even if you are not able to differentiate, that's okay, but whenever you see this branching pattern, you have to send that patients to VR. What exactly this IRMA is, it's basically a branching pattern at the zone of vascular non-perfused or perfused area. So whenever the perfusion area ends, that is where this IRMA develops. So they develop from a normal vascular pattern. These are the not abnormal fragile vessels, which are actually the neovascularizations. And how to differentiate it clinically? This neovascularization generally develop over the surface of the retina, while these are intraretinal. Okay, so this is the one which we can decide clinically. Second, we can differentiate on the basis of angiography, if we have angiographic facility. So angiography, this neovascularization leaks a lot. In early it will show early hyperfluorescence. While IRMA, it doesn't leak or a mild leak you will see on fundus angiography. So very severe NPDR, 4 to 1, these 3 features: intraretinal hemorrhage, IRMA, and venous bleeding. Now come the proliferative part. I feel like the proliferative diabetic retinopathy, it's most of the time it's easy to pick. When comes the confusion, when we see these kind of neovascularization, sometimes it's difficult to identify. So whenever these neovascularization is there, this patient needs treatment, and when this neovascularizations bleed over the surface of the retina, in between the hyaloid and retina, it is called pre-retinal hemorrhage, and sometimes it bleeds into the vitreous cavity and becomes vitreous hemorrhage. Okay. And when this neovascularizations become fibrous, that at the time it start contracting, and patient may develop into tractional or combined retinal detachment. So you will be seeing a more fibrous, matlab whitish tissue rather than the reddish tissue. Then it is a patient who needs to be referred to a VR person. So we have learned NPDR part, we have learned the PDR part, and third is macular edema. So far we have learned clinically significant macular edema by ETDRS classification. That is also confusing from general ophthalmologist point of view. Now we recommend you need not to understand what is clinically significant macular edema. All edema which is center involving macular edema should be referred to a VR person. So if you are seeing hard exudates center of the macula, how you will identify how much area you will take? It should be a 1 disc diameter area that is sufficient enough you to decide whether it has to be referred to a VR person or not. So take home message is, just remember these 3 parts: very severe NPDR, PDR, and central involving macular edema. And very severe NPDR ke liye you have to remember 4 to 1 rule. That is these simple 4 steps. If you will learn, you will become kind of even better than a AI rather than I must say. So AI is good, but we should be having at least a basic learning of diabetic retinopathy that we should not forget. Thank you.
Thanks, Manish, for being in time. So I think we are nearly in time. Dr. Ajay Dudani, Professor Ajay Dudani is a famous veterinary retinal surgeon from this part of the country only, from Mumbai only. And he has been a very close friend of mine, and I invite him to talk about clinico-investigative correlation. So that is a bit of diabetes we are going to teach you. Till now, we were only telling you about how to do the screening part. So enjoy this clinico-investigative journey into diabetic retinopathy.
Thanks for your kind introduction. I'll try to just present my cases. ये नहीं है, ये वाला दूसरा सेशन. ये, हाँ ये वाला. इसका ना पहले ये करो, स्लाइड सॉर्टर करो, स्लाइड सॉर्टर ये करो. Can I have the slides, please? Slides दिखाइए. So I'll be talking to you all briefly about few cases where we are treating diabetic macular edema, the difficult cases. Yeah. So these are the, we call as the, rebellious rebels of diabetic macular edema, which is one of the most treatable conditions. So, in your patients, you normally expect the unexpected. You would have expected a rebellious DME which doesn't respond to your normal treatments, like you cut open an apple and you get an orange. And then our major problems which we face in India is our patients, where the patient is a rebel. He's just standing on his head rather than getting treatment when he's advised. So diabetic macular edema, as we know, is a battle of cytokines like COVID was, because DME is a multifactorial disorder, and when you have a problem, would you call a Justice League or a Batman is how I give a corollary in these treatment patients, in these patients. So progression to PDR in NPDR patients occurs in 5 years, and Ozurdex has a long duration of action which ensures compliance and controls visual acuity in these patients. As we are aware that, we have two lines of treatments. One is anti-VEGF and one is steroids. But in patients, we have seen that in the RISE and RISE, where we are using anti-VEGFs, almost 60% of the patients fail to meet the endpoint of resolution in macular edema. And the pathogenesis of DME is multifactorial. So here again, directly going to my cases, we have the rebellious patient where the compliance is very poor. Even in USA, 75% of the patients receive the first 3 injections in their first year and then they drop out, as we all aware in our practice. So Avengers of DME, what I call is like, where we have all superheroes to rescue rather than just the anti-VEGF agent, which is the Batman, which comes into play. So these are the trials which are done on Ozurdex. And this is the registry for DME, where they've shown that Ozurdex implant is also a very effective treatment along with anti-VEGF in these patients. So I'll directly go to my few cases which will make this presentation interesting. This was a 70-year-old lady with uncontrolled diabetes of 25 years. She had severe NPDR with DME. She underwent ranibizumab with laser, then cataract surgery under eccentrics cover. And then she was switched from eccentrics to Ozurdex. I'll show you all why. And she's received about 5 injections over the last 3 years. And today her vision is maintained at 612, 618. So this is how the story starts. The left eye, there was a DME with severe NPDR. Right eye also, there was DME. It responds to ranibizumab. You can see that the foveal contour has come back. Then there is recurrence in the right eye. Left eye also recurs. Then it started non-responding to ranibizumab. That's when you're stuck up your patients. You've done laser, you've done injection. It's not responding. And the left eye develops tachyphylaxis also. You can see that the macular edema is persisting. That's when we decided that we'll switch over to Ozurdex in this patient. And then that's the Ozurdex calm which we receive, that the foveal contour comes back. But it tends to wax and wane. It's not that it's a, it's a panacea treatment. But this is the foveal dip which you get with steroids, which you might not necessarily get with anti-VEGF in all your cases. Left eye is tough to treat. It receives another Ozurdex in this eye. It's better now. Yesterday only the patient came back to me. The left eye has again shown up, after 4 months of Ozurdex. So it's not that it's a panacea treatment. This is again a one-eyed patient who has lost the other eye to proliferative diabetic retinopathy. Is uncontrolled diabetic, received Avastin, multiple PRP sessions for PDR over 9 years. He was 660, and that's when we switched to Ozurdex. So this is how he was, You can see this opaque intraretinal fluid here, which is there. So there was no response after some time, and this is the post-Ozurdex magic. As you can see that the foveal contour has stayed. He came back last 6 months back, and the fovea has remained flat. So this diabetic maculopathy is a finite condition which requires limited number of injections, unlike AMD, which is a lifetime treatment which requires treatment with anti-VEGF. So this is a 75-year-old male, uncontrolled diabetic for last 30 years, received some laser and injections. Again, a one-eyed because the right eye has undergone foveal atrophy. You can see the left eye, the extensive macular edema with a drill sort of a picture. There's a loss of inner retinal architecture with loss of RP. Also here you can see the EZ zone has started to get disrupted with VMT also. So this is how the Ozurdex calm came after an injection when he had received injections elsewhere, but this is the response we got to a single injection at 2 months, the foveal dip. And his vision also improved. It's not just that the anatomy only comes back, even the function comes back. But then it tends to recur. Many people will say to remove this ERM, but I didn't, and it responded again well. Vision came back to 618. Again it recurred, and then we had that COVID shutdown, where patients didn't follow up, and we lost all these patients, and they lost to, had poor vision come back. So this is when he lost to follow up. This is again a patient who is like, 58-year-old gentleman, 30 years of diabetes, and he has received multiple Avastins and laser, and he had that persistent cyst which I'll show you, which, so this is how it starts, the story in 2012. Right eye, left eye, both you can see that cystic edema, which does resolve to Avastin, but it doesn't like totally go away, And this is the response I got to a single injection of Ozurdex, where the foveal contour came back so beautifully, in this patient. But it does recur. It again responds to Avastin. This is a patient who developed a occult CNVM, as you can see in this patient, in a patient who was a diabetic with PRP who had done, and we again had to give him, move back to eccentrics for that occult CNVM. So this is again a post-cataract bilateral DME who received Ozurdex. You can see this is the right eye, left eye. So he had a combination of Irvine gas with DME, and this is the response we got. It came back again, but it responded very well. But these cases do tend to come back, but after few years they do settle down, and it's a finite condition. So this is a gentleman who had lost one eye to post-injection endophthalmitis, and the left eye also was having diabetic macular edema, but he refused any injection for obvious condition because he has lost one eye to an injection in this eye. So I just wanted to show you that how a good metabolic control can actually control diabetic macular edema with topical drops. So this is how you can see the response here. The cyst comes back, but this is all without any injection. Over a period of 4 years, you're seeing a patient following up with just topical therapy. The topical therapy I give is NSAIDs, prednisolone acetate, and acetazolamide drops, that is Azorb drops. Just last one patient I'll share with you. This is a teacher who underwent treatment with me, for diabetic macular edema. This is the right eye, left eye. You can see there's a subserous fluid also in this patient. So this did respond to Avastin with laser. This is in 2012, so you have almost a 10-year follow-up, but this is the foveal contour which comes back with a combination of laser and steroids, Ozurdex in this patient. Until 2021, over the last 3 years after the last injection, she has remained flat. So this condition, if you treat it well, it's a finite condition, and diabetic macular edema can be treated when you follow up the patient very closely in the acute phase when there is macular edema. So this is the foveal contour, the dip which has stayed persistent for the last 2 years without any more injections, and with a good control in this patient. So this is what I learned over a time, that these chronic cysts in a patient, this is a 10-year-old follow-up, this was a cyst in a patient, an educated patient, a subfoveal cyst, which responded to Avastin, but it came back. It used to keep coming back and never disappeared, So this is when we switched to Ozurdex, and you can see this cyst disappearing permanently. So that opaque fluid which you saw in the cyst was showing that it's an inflammatory component and responds very well to Ozurdex, and this has stayed flat for the last 4 years. So from 2018, this is how it has stayed without a single injection or a drop, you know. So I think I'll stop at this because the time for the other session. Thank you so much for your patient hearing. Thanks.
So I think Dudani's presentation has always been very scintillating. And what we are now thinking that is diabetic edema is is diabetic retinopathy an inflammatory disease? With this, I think we call off this session. And I call all my participants to please come and so that we can have a photograph. And then we'll hand over to the next. We are handing over in time.